Hello and welcome to another edition of Around Town. I'm Kyle Schwartz, and today we're in Fairlawn where we're talking with Dr. Kostas Apostolos about the practice of, or the theme today is to mesh or not to mesh. So thank you for agreeing to do this interview, Dr. Apostolos. Before we get into that topic, let's talk a little bit about yourself. Tell us about your background and your practice and your schooling, that type of thing.
Sure. Thank you for the opportunity. I'm originally from Beaver Falls, Pennsylvania, born and raised. My parents came from Greece in 1973, so essentially lived the whole immigrant dream of coming to the United States and for a better future for their families. I have two brothers. One is a pulmonologist in Boardman, and the other is an internal medicine doctor in Youngstown as well. I've been here in Akron for about 6 years with my wife and my two lovely children, Kyriaki, who's 3.5, and my son, Argyri, who is 1.5 years. So we've been here in Akron for approximately 6 years, practicing urogynecology.
Okay. And where did you go to school?
I did my residency training at Winthrop University Hospital on Long Island, New York, my fellowship training in female pelvic medicine and reconstructive surgery, which is a fancy way of saying urogynecology, with the Harvard Medical School in Boston.
Okay. So how did you decide on that practice? I mean, it's interesting that your brothers, all three of you, chose a different type of specialty. So why did you choose that?
When I finished medical school, I knew I wanted to get into something surgical. And I had started out at the Western Pennsylvania Hospital in Pittsburgh in general surgery residency. Well, I quickly learned that the more intimate nature of medicine was something that I truly enjoyed. Not just seeing patients, rounding, that sort of thing. And so I decided to go into obstetrics and gynecology. And at that point, I completed 4 years of OB/GYN, delivered thousands of babies. And given my passion for surgery, I pursued a fellowship in urogynecology. Urogynecology is the type of field where women come in with a certain quality of life issue, whether it's leaking urine when they cough, sneeze, laugh, or the feeling that they have to go to the bathroom all the time and can't make it, or having an immediate bulge or a sensation of vaginal fullness. What urogynecology does is take women through diagnosis and treatment and essentially change their lives. It's a quality of life dedicated field which gives women essentially their lives back to be able to enjoy.
Okay, well that sounds very, very interesting, and I'm sure you get a lot out of that personally. One of the surgeries that you perform is for vaginal and rectal prolapse, and that is kind of why we're here, because there was a recent 60 Minutes program that I'm sure you got a lot of phone calls at your office after that show aired, and it was about a number of lawsuits that were being filed because of a specific type of mesh and what some doctors were using and practices. So what happened on a personal note is that my mother was having surgery with you, and she saw that and she said, "Oh, I don't think I want to do this," and so I watched the program and I said, "Yeah, I don't think you want to do this." But I called you and you were kind enough to talk us through this. She did have the surgery. It was with great results. But so how do we respond to that? Because there were so many people that saw that and might have called off their surgery or might have decided not even to consider that surgery because it was a scary program. As far as that mesh itself is concerned, you said that is not even something that you use in your practice, that particular brand?
As far as mesh is concerned, the treatment for women suffering with incontinence and prolapse has changed dramatically over the past 30 years. Surgery for prolapse and incontinence essentially used to use, in the 1980s, women's own tissue to kind of put back or repair defects or tears in tissue that were caused by vaginal deliveries. Well, in the early 2000s, urogynecologists started to use mesh in order to augment or help to support those tissues that were broken, because success rates without mesh were quite dismal. Well, when we started using mesh in the early 2000s, we didn't really know much about it. So we were using the same type of mesh that general surgeons were using to fix hernias. Well, very quickly, over the ensuing 7-8 years, we learned that women were coming back with vaginal bleeding, with pelvic pain, with the mesh eroding or moving into the vagina or into the bladder or into other organs. It started to get on the radar. And the FDA in 2008 made an initial warning letter that said, maybe you guys need to look into this mesh that we're implanting in women because we're starting to hear some complaints. Well, then in 2011, the FDA came out with a second warning and said this is a serious issue now, and all physicians who are implanting mesh really need to consider who they're implanting the mesh in, and we need better studies, better research to determine why it is that mesh is causing these problems. Well, Kyle, I can tell you, we've learned a lot over the last 18 years with the use of transvaginal mesh. And I can tell you that I am a very big proponent of the use of mesh for prolapse and incontinence repair. Why is that? Because in the appropriate patient, and I think this is the main issue, mesh repairs are not for everybody. I think the number one point is to make sure that you're being seen and treated by a specialist who has the FPMRS tag behind their name.
Okay.
That means that that is somebody that has completed a fellowship or is board certified in performing mesh type repairs, has the specialized training to call themselves a urogynecologist. Number two, when we talk about mesh, there's two categories. Number one is mesh for incontinence.
Okay.
And number two is mesh for prolapse. The American Urogyne Society and the American Urology Association and the International Continence Society have all put out statements in regards to the incontinence mesh. When we talk about incontinence mesh, it literally looks like a shoelace.
Okay.
It's a 1.5 centimeter strip of mesh that fits under the urethra, the tube that we urinate through, to support the urethra to help prevent leakage. Leaking when you cough, sneeze, laugh, any exertional type leak, which we refer to as stress urinary incontinence. And there's a specific workup that goes into that your doctor should be able to guide you and counsel you as to whether a sling, which is what this is called, a sling is the right thing for you to do. Slings are essentially 90 to 95% effective in curing incontinence with minimal side effects and minimal issues as related to what we're seeing on TV. Okay?
Right.
So two different categories of mesh that women should know about, and a sling is specific for urinary incontinence and widely approved and accepted as the gold standard treatment for stress urinary incontinence. Well, that brings us to the bad mesh, okay? And the mesh that 60 Minutes was recently talking about, and all the different lawyer advertisements and things that we're seeing on TV. When we talk about mesh for prolapse, mesh has evolved significantly over the last 18 years. We used to implant heavier meshes, thicker meshes, that would cause the problems that are being reported. Pain with intercourse, vaginal bleeding, erosion or movement of the mesh into the vagina. Today, in this day and age, there's been extensive research done on mesh. And it wasn't really the mesh's fault. I think there's a couple reasons why we've found ourselves in this particular issue. Number one, having surgeons and physicians implanting mesh that probably weren't qualified to do so. And when I say qualified, it's not necessarily the technical aspect, but choosing the appropriate candidates for mesh implant.
Now, how do you know who the appropriate candidates are?
Given what we know about mesh today, mesh has a tendency to react differently in different people. What does that mean? In younger, healthy, sexually active women, in my opinion, transvaginal mesh may not be the right thing to do, because we use big pieces of mesh through the vagina to suspend their prolapse to ligaments inside their bodies. Well, that mesh is a lot closer to the outside world when we incise the vaginal skin. So in healthy, sexually active women, it's my personal practice, I do not do transvaginal mesh. In older women who are not sexually active, and that's the turning point for me. When a female tells me that they are sexually active, transvaginal mesh essentially is not going to be an option. In women who are not sexually active, transvaginal mesh is a great option because it allows us a minimally invasive approach to fixing their prolapse without having to go into the belly. 35, 40 minutes and their procedure is done. Their quality of life is improved dramatically, and the risks are minimal. In sexually active women, when we perform transvaginal mesh, studies have shown a 20 to 30% risk of pain or discomfort with intercourse. And I think that's the major point that people need to be aware of, that these procedures are not for everyone.
Okay. All right. So in your practice, what is the success rate? Because I know that was a big thing on 60 Minutes. There were so many people coming back that, you know, had these terrible outcomes, but you've had really good success rate with.
Thank God. Yeah. As far as our outcomes are concerned, as I mentioned earlier, each patient is looked at individually, and their needs are taken into consideration when we tailor the types of treatments that they need. Quick point about the 60 Minutes show. I have to say that a lot of what was discussed on 60 Minutes, I have a really hard time believing. I've worked with Boston Scientific. I know their products. And a lot of what was portrayed during that broadcast was absolutely false. And not in Boston Scientific's defense, but being that I know the field very well and I've represented a lot of different companies across the country, I just think it was an unfair view into what Boston Scientific has to offer. The mesh does not disintegrate. The mesh does not go into other organs and things as was suggested unnecessarily. I just really think it was an unfair blow to Boston Sci, and overall to women that are considering mesh repairs. We got hundreds of phone calls for the ensuing couple days after that broadcast, just like you did, and your mom, you know, to ask about, wait a minute, am I getting that bad Boston Scientific mesh? Well, no, you're not. But let's talk about, you know, what that commercial broadcast was all about.
Okay. Well, you know, and I can be honest, I really never heard of a urogynecologist until this as well. I thought there were gynecologists and there were other specialists, but I had never heard that before. So just to get off the topic for just a second, what are some of the other things that you do to improve quality of life for women in your practice?
As a urogynecologist, not only do we treat urinary incontinence and prolapse, but we also treat recurrent urinary tract infections. We treat fecal incontinence, and fecal incontinence affects anywhere from 3 to 13% of the female population, mainly from traumatic childbirth. We also treat women with pelvic pain, and all pelvic pain is not the same. I would urge women that have pelvic pain to seek out a urogynecologist, and there's a number of us here in Akron as well, and have an evaluation before considering hysterectomies and having your ovaries and tubes removed. There's causes that are often overlooked, and those can be easily diagnosed by a urogynecologist. We treat pain with intercourse and vaginal dryness and what's called vaginal atrophy, conditions that can significantly affect your intimate life. Fistulas, different types of fistulas, which are communications between bladder and the vagina or the rectum and the vagina, where women can literally pass stool from the rectum through the vagina or leak urine from the vagina, from the bladder into the vagina. And so there are lots of minimally invasive ways that we can potentially treat those things as well.
Okay, so to someone that's watching this show, what are a couple questions that they should ask their urogynecologist before they have any type of procedure done? Are there some key questions to ask. You've gone over them a couple of times, but
Absolutely. I think number one is for all women who are suffering with these issues. My point has always been, since I came to Akron, is to start the conversation. You don't have to live with prolapse and incontinence and pelvic pain and recurrent urinary tract infections. There are things that women can do. Number two, it does not always mean surgery. All right. Each person and each condition is looked at separately. A urogynecologist will discuss both the non-surgical and potentially the surgical options that might exist. A lot of women fear or shy away from coming to the doctor because of the fear of surgery. That's not the case. There are non-surgical things that you can potentially do. I think when looking at your options with a urogynecologist, I think the important thing to consider is, are you seeing a urogynecologist, or are you seeing a general urologist or a general gynecologist who may very well be doing a great job? But these issues have become very specialized, and so it's important to get to the right place, if not for anything else, to make sure you have all your options. Because as a subspecialist, we are dedicated to staying up on the latest and greatest techniques and
I'm sure
treatment
it
modalities.
changes all the time,
It
too.
changes constantly. So you want to be seen by somebody who has that information available to them. Don't ever be afraid to challenge your doctor about the procedures that they might suggest, to seek second opinions. I always think second opinions are important and appropriate, especially when more invasive procedures are being suggested, just to give you peace of mind. Doesn't necessarily mean you have to go to the second opinion if you're comfortable with your doctor, but at least that you know that you're doing the right thing and that you're getting the best possible treatment.
okay. Well, that's really all I have, unless there was something that you wanted to add.
I appreciate your time and everything that you're doing here. Our message is that you don't have to live with these types of issues. We've also started offering what's called DIVA, which is vaginal laser therapy. And laser therapy has been around for about 10 years now. And it's essentially added another way of treating vaginal dryness, pain with intercourse, and urinary incontinence, short of surgical procedures. And it's a simple office-based procedure that we've been getting great results with. So something that is definitely worth talking to your physician about.
Okay. Well, sounds like an interesting new development, as is always coming up in the medical world, and we really appreciate you staying up on all this, and we appreciate what you do, and thank you for being with us
My
today.
pleasure. Thank you, Kyle.
And thank you for watching Around Town.